Yep.
Okay. So thank you, Chantel, for inviting me. I kind of came across Dr. Gordon in a way that I really didn't want to. In March 2020, I was diagnosed with breast cancer at the onset of the pandemic. And then I had my treatments. They obviously were delayed because of the pandemic, or at some point they didn't know if we'd even have them. So it kind of contributed to me being off for approximately 3 years because I did have some other health issues. During that time, I was listening to a lot of podcasts, and one I really did like was CBC Listen, and Dr. Gordon was on there. So that got things churning for me to take a deep dive into dense breasts, what that means, the screening guidelines in New Brunswick in particular. And it was really brought home because I have BI-RADS D breasts, and I obviously have breast cancer, and I was denied supplemental treatment earlier this year. So that got me on this journey, and that's where we are tonight. So that, and I did a quick poll just around Christmas time if people even knew what the breast screening guidelines or the stepwise approach was in New Brunswick, and there was some confusion. So that's enough about me. I would certainly love to introduce Dr. Gordon. Dr. Paula Gordon was recently awarded the Order of Canada. She is a clinical professor in the Department of Radiology at UBC and has been in practice for almost 40 years. She is the founding medical director of the Sadie Diamond Breast Program at BC Women's Hospital and a founding member of the Canadian Society of Breast Imaging. Her mission is for as many breast cancers as possible to be detected early, to give women more options for less aggressive therapy, and to reduce breast cancer mortality. She's a fierce advocate for advancing women's knowledge of breast health and screening options, including supplementary screening for women with dense breasts. So no further ado, I thank you, Dr. Gordon, and I'll hand it over to you.
Thanks, Joni, and thanks, Chantel. Thanks so much for inviting me to give you an update on optimal breast cancer screening. Now, there's been some progress, but still no province achieves the ideal. So here are my disclosures. I'm here on a volunteer basis, and I'm not paid by industry for lecturing, and I have no financial interest in any technology associated with breast cancer screening. In my last webinar, I discussed the benefits of early detection, how and why we try to find breast cancer as early as possible, and I discussed the possible risks of screening. I described the randomized trials that were used to arrive at the recommendations for screening by the Canadian Task Force of women who are not at increased risk. And I explained that annual screening, starting at 40, saves the most lives, and that the Canadian Task Force is the most significant barrier to optimal screening across Canada. So today I'm going to show you some more recent work supporting screening starting at 40 and supplemental screening for women with dense breasts. And I'm going to go into more detail about the flawed Canadian study that is still being used, resulting in the task force guidelines being outdated and dangerous. Now, as a reminder, the task force is a volunteer committee that makes screening guidelines for primary care providers, and they're described as being experts. For the breast cancer guidelines, the chair of the committee was a nephrologist. There were family doctors, nurses, and epidemiologists. There was an occupational therapist and even a chiropractor. The task force deliberately excludes content experts from all of its guideline panels. So there were no breast cancer experts on the panel that made the breast cancer screening guidelines, and there were no prostate cancer experts on the prostate screening panel, etc. Now, most family doctors and nurse practitioners are shocked to learn about the deliberate exclusion of experts on these panels. The task force is funded by the Canadian Ministry of Health through the Public Health Agency of Canada. And note that for COVID, PHAC relied on experts to make guidelines for preventing and treating the disease. The structure of the task force was set up so that they're arm's length and they're not accountable for their recommendations. They decided to use only a specific kind of research called a randomized trial to determine what the benefits of screening are. And that would have been reasonable, except those trials, it would have been reasonable if they were all high quality and they used modern mammography equipment and modern therapy, but they did not. So here are the current guidelines that were issued in December 2018. They concluded that for average risk women aged 40 to 49, that the harms of screening outweigh the benefits, so that women that in that age group should not be routinely screened. But they erred in who they described as being average risk. They didn't include women with dense breasts or even with women with a first-degree relative, a mother or sister with breast cancer. They recommend that women should be screened from age 50 to 74 and only every 2 to 3 years. They recommend against doctors and nurse practitioners doing clinical breast exams, and they recommend that women should not do breast self-exams. And they recommended that women with dense breasts do not need supplemental screening. Now, your group knows the basics, so I'm not going to repeat them other than to remind you that breast cancer does not become life-threatening when it's confined to the breast. Many breast cancers can be found before they spread, and when they are, women are less likely to die, and they can be successfully treated less aggressively. So the first goal of early detection is to reduce deaths. The proof that screening mammograms save lives was established by randomized controlled trials. Now, we've been studying mammography for almost 60 years, and the youngest of these trials was done 36 years ago. The trials in Canada were done over 40 years ago. So bear in mind that all of them used X-ray film mammography, which is no longer used anywhere in Canada because it's been replaced by digital mammography. And even though the trials were of different designs and included women of different ages, these randomized trials are usually lumped together in what's called a meta-analysis. And overall, they wasn't bad. They showed 15 to 20% fewer deaths in women invited to have mammograms than the women in the control groups. But the two from Canada, which I've outlined here in red, they were outliers. They were the only ones where women were actually more likely to die of breast cancer if they were put in the mammogram group. Now, today I'm going to update you on the progress that's hopefully going to get them retracted from the literature. And that's essential because until they will continue to be used by the task force and policymakers, even in other countries, to deny the possibility of early detection for women, especially aged 40 to 49. Now, we know that the flaws in design and execution of these 40-year-old trials led to these results. They were compromised and they're invalid. Now, last time I didn't have time to go into the problems with you, but I will this time. Now, in contrast, I'm going to introduce you to the current evidence that's in favor of screening starting at 40. This Canadian high-quality, non-randomized study from 2014 showed significant mortality reduction. They studied almost 2.8 million women, and they showed 44% mortality reduction for women aged 40 to 49. They even did a sub-study that confirmed that even though it wasn't a randomized trial, that there was very little selection bias. But this study was ignored by the task force when they made their most recent guidelines. Now here's another. The Swedes looked at 58 years of data collected on just over 50,000 women in one county in Sweden. And rather than look at all the breast cancers, they focused on those that became fatal. Now, by doing so, they eliminated lead time bias and overdiagnosis. They showed that women aged 40 to 69 who chose to be screened were 60% less likely to die in the first 10 years after they're diagnosed, and they're 47% less likely to die in the 20 years after their diagnosis. Of course, women diagnosed with breast cancer receive state-of-the-art treatment, whether they had screening or not. But these results demonstrate that women who've participated in mammography screening obtain a significantly greater benefit from the therapy available at the time of diagnosis than those who have not had mammograms. This research looked at over 7,000 women diagnosed with breast cancer over a 10-year period at 2 of the hospitals in the Harvard system. And they also studied just the women who died. There were 609 that died of breast cancer and 905 who died of other causes. 71%, the majority of the deaths, occurred in the women who did not have regular mammograms. And the rest, the 20% or so, the rest of the deaths occurred in women who did have mammograms. Now, importantly, of all the breast cancer deaths, only 13% occurred in women 70 years or older, but 50% of those deaths occurred in women who were diagnosed when they were younger than age 50. This also drives home the point that women should start screening at age 40. Now, of course, breast cancer is less common in women in their 40s, but it grows faster. So we want to find them, especially in these younger women, as early as possible. Now, there are many other high-quality, non-randomized studies ignored by the task force, but time limits me from going into more detail. So, in addition, there are international standards for how to create guidelines, and the Canadian Task Force says that they used GRADE when they decided to look at only randomized trials. You're probably familiar with GRADE. GRADE stands for the Grading of Recommendations, Assessment, Development, and Evaluation. It's a system for rating the quality of evidence, and it was invented at McMaster in 2004. It's one of several international standards for how to create guidelines. But the task force misapplied GRADE. In GRADE, randomized trials start out as the highest quality evidence, and observational studies are the lowest quality. But GRADE also states that both can be moved up or down in quality based on the implementation problems, the magnitude of the benefit, and so on. Now, our task force claims to use GRADE, but by only using randomized trials, including the highly flawed Canadian studies, and ignoring all the more modern high-quality observational studies, they have misapplied GRADE. And in doing so, they missed the opportunity to see additional important benefits. Randomized trials showed that we can save lives doing mammography, but in addition to saving lives, the other important goal of early detection is to improve the quality of life for women with breast cancer by allowing them to have successful treatment with less aggressive therapy. When cancer is detected early, women can avoid having a mastectomy and be successfully treated with lumpectomy. The task force did not consider that as a benefit of early detection. I'm sure you know this is an example of lymphedema, and it's a swelling in the hand and arm from blockage of the lymph vessels in the armpit, which is a side effect of the traditional axillary dissection done as part of breast cancer staging. It's usually permanent, and as you can imagine, it's life-changing. It's arguably the worst part of breast cancer for many women. The risk of lymphedema after axillary lymph node dissection is up to 33%. When cancer is detected early, women can have a sentinel node biopsy instead, with a risk of lymphedema as low as 5%. Now, this is another reason we want to find cancers as early as possible, not just to save lives, but so women can avoid this complication of lymphedema. And that's something the task force ignored. Chemotherapy, of course, is challenging, and some women suffer long-term complications. But now, with genomic testing of the tumor, many women can avoid chemo if their cancer is small and at a low risk of recurrence. Another reason to find cancers early that the task force ignored. These researchers from New York showed that women who have screening less often are more likely to undergo mastectomy, require axillary dissection, and need chemo. This is certainly the case with the task force's recommendation that women 50 to 74 have screening only every 2 to 3 years. So by using only mortality reduction as a benefit, by using the 20% number from the randomized trials rather than the 44% mortality reduction in the observational studies, and by not looking at the options for less aggressive therapy, the task force is vastly understating the benefits of screening. So those are the two benefits of early detection: to save lives and to improve the quality of life by allowing less aggressive therapy. The task force understated the benefits, and they compared them to what they regarded as the harms of screening. In my opinion, a better description would be to say the risks of screening. So what are those so-called harms that the task force feels they outweigh a mortality reduction of 44% and the opportunity to avoid aggressive therapy in younger women? The two they're most concerned about are what they call the false positives and overdiagnosis. So think for a second, what does false positive means? It means that a woman was told she has cancer when she doesn't. They're not referring to that. They're actually referring to when a woman is recalled after screening to have more tests, to check out something that needs more assessment. So to use the term false positive is really misleading and pejorative. A better term would be false alarm, and lots of findings require additional investigation that prove to be benign. For example, masses like cysts and fibroadenomas, for example. Recalls are most common when a woman has her first mammogram because we have no priors for comparison. And here are the real life numbers. For every 1,000 women screened, on average, 930 or 93% will get a normal result. 70 women or 7% will need additional tests. Now, the majority of those women will only need one or more additional mammographic pictures or maybe an ultrasound. 11 of the 1,000 will need a needle biopsy, and those are done with local anesthetic, and they should not be more painful than a blood test from the arm. 4 of those 11 women who have a biopsy will turn out to have cancer. The anxiety from a false alarm is real, but it's transient, and women can handle it, especially if they're informed ahead of time that it might happen. Women are familiar with false alarms from pap smears, so it's not a good reason to deny women mammography, because then we lose the opportunity to find those 4 cancers early. This chart is from the Canadian Partnership Against Cancer. You can see the false alarm rates for women in each of the decades, the 40s, 50s, 60s, and 70s. The tall blue columns represent the recall rate during the woman's first screen. And recall is always higher the first time a woman has a mammogram, no matter what age she starts, and then it decreases. So that's not a reasonable justification to make women wait until age 50 to start having regular mammograms. In fact, the cutoff of age 50 has no scientific basis as a threshold for screening. The anxiety when a woman is recalled for additional tests, as I said, is very real, and it can be significant, but it's transient. And it's been shown to have no long-term effect. But the task force gives it equal weight as a risk to the benefit of averting death. So they recommend starting screening later and screening less often, even though they know that more women will die. And women disagree. Researchers in Pittsburgh surveyed 1,500 women attending screening and found that 97% of them would be happy to have regular screening, even if it meant being recalled with a false alarm. And 82% said they would have no trouble having a needle biopsy if it might increase the chance of detecting cancer earlier. So that's what your patient has to consider when you have a shared decision-making discussion with her about whether she should have mammography screening. Remember, 4 of those 11 needle biopsies are cancer. Now, even though the task force said we should not routinely screen women in the 40s, they did say that women should have a shared decision-making discussion with their primary care provider, family doctor, nurse practitioner. And if she chooses to be screened, she should be allowed to be screened. But unfortunately, that little detail didn't get through. And so many primary care providers don't realize that they should be giving women requisitions after that conversation. In this comic, the task force member says, looking down at the grave, yes, regular mammograms and early detection would have saved your life, but aren't you glad we spared you all that anxiety? Women find this patronizing and condescending. They can tolerate transient anxiety. It should not be up to a committee of non-experts to decide whether she should be denied screening and lose the opportunity for early diagnosis. In my opinion, rather than deny access to screening, we should be working to shorten the wait times for women to have their diagnostic workups. Another risk of screening is called overdiagnosis. That's a theoretical possibility that some cancers we find at screening would never surface on their own before the patient dies of something else. In other words, there's really no need to find them. For example, there are some cancers that grow so slowly that if a woman has other medical problems, they might never become life-threatening. Or a woman might die of something else before her cancer becomes life-threatening, like heart disease or a different cancer or even a car accident. But that's not a reason to not screen all women, because then we lose the opportunity to find the lethal cancers. The risk of overdiagnosis in younger women is almost zero because they're less likely to have other diseases. The challenge is that overdiagnosis can't be measured directly, and it has to be estimated. Italian researchers looked at 16 estimates of overdetection from 13 European observational studies. After correction for baseline incidence trends and lead time, overdetection estimates fell into the range of 1 to 10% and probably closer to 1%. Contrast that with the Canadian task force. Because they used the flawed Canadian study, they vastly overstated the degree of overdiagnosis to be 32 to 55%. So in summary, the task force recommendations were based on their weighting of the benefits and the risks, but they understated the benefits by using the underestimate of mortality reduction shown in those old trials rather than the mortality reduction we now know is possible from observational studies. They ignored the significant benefits of being able to have less aggressive therapy when cancer is found early. And against that, they overstated the risks of screening by inflating the harm of transient anxiety from a recall and by overstating the incidence of overdiagnosis. Essentially, the task force decided that women shouldn't be trusted to make the decision to be screened because they were too delicate to handle some transient anxiety or comprehend the possibility of overdiagnosis. So they made this decision for women. It's as though they've said, don't worry your pretty little heads about it. Women can make up their own minds whether it's worth risking a recall to potentially avoid a breast cancer death. So with that background, I want to spend a few minutes discussing those Canadian trials with you and the flaws. The Canadian National Breast Screening Studies, we also call the CNBSS. Those were the two trials done in Canada between 1980 and 1988. And as I mentioned, they were the only ones to not show mortality reduction, and they should not be used by the task force, but they are. And here you can see they're the only two where they were below the zero line. There were two separate trials. CNBSS 1 was meant to be a randomized trial of screening for women aged 40 to 49. Women in the study group had an annual mammogram and a clinical breast exam, and the control group had only what they called usual care in the community. Now, women were asked to volunteer, and to be accepted for the trial, they had to be age 40 to 49 with no history of breast cancer, have not had a mammogram in the previous 12 months, not be pregnant, and they had to sign a consent. Listen to this. Having a known breast lump was not an exclusion criterion. Women with lumps were welcome. Well, that's red flag number one. Screening is for asymptomatic women. So from the get-go, this wasn't really a trial of screening. That's one of the many fundamental rules broken in the design and conduct of this study that have rendered the results invalid. All the other randomized trials were population-based from a pre-selected population. Some women were invited to attend for a mammogram, and they were the study group. For example, in Sweden, where healthcare is delivered by counties, women in some counties received invitations and women in other counties didn't. Those who didn't get invitations were in the control group. They didn't even know there was a study going on or that they were the control group. They just lived their lives. But for the CNBSS, they advertised for participants and asked women to volunteer. That's red flag number two. This was not a representative sample of the population, since women are motivated to volunteer for various reasons, and there would be segments of the population who never even heard about the study or saw the ads. Mammography was not widely available in the early 80s, so women with a family history or women with a breast lump were incentivized to enroll in the study, and some women volunteered for the trial hoping to be put in the mammogram group. Now, some of these women were assigned to the control group, who were understandably disappointed, and they asked their family doctors to send them for a mammogram outside the trial, and many did. Now, let's say that a small cancer is found in some of these asymptomatic women. The women are treated, they do well, and they don't die. That decreases the number of women dying in the control group, because even though their deferred death was because of having had the mammogram, it's counted as them being in the control group. This is called contamination, and it was far more frequent in the Canadian trial than the others, simply because of the women being recruited as volunteers. According to their own publications, 26% of the women in the 40s assigned to the control group had mammograms outside the trial. And this is one of the reasons that more women died in the mammogram group than in the control group. Also, recruitment wasn't going well, so women were recruited directly from doctors' offices, including breast surgeons' offices. And many of these women were seeing the surgeon because of a breast lump. Remember, having a lump was not an exclusion criterion. The biggest problem was that the study design led to flawed randomization. Now, in a well-conducted randomized trial, subjects are divided into two groups, and the group should be ideally identical in every respect except the intervention being tested, in this case, the mammogram. And the subject should be randomly assigned to either group. So in this schematic, here's the total number of women, and the women in the red women are the women who will one day get breast cancer at some point, but of course we don't know who they are. If the study is conducted well and women are randomized, the number of women in each arm, the control and the study arm, should be roughly equal. And that's was the case in this situation. Here we have it like this. If you put all the red ones together, you can see that women destined to get breast cancer is equal in the two groups. And if you did nothing else, the same number of women would probably die in each group. Those are the black figures. If you screen one group on the left and not the other on the right, and if fewer women die in the screen group, here there's only one compared to 3, you can, and if the difference is statistically significant, you can say that it was due to the mammogram. As I've shown in all the trials except Canada's, there were fewer deaths in the invited women. So we can say that it was the invitation to screening that led to fewer deaths. If the randomization is compromised, either intentionally or unintentionally, then this situation can arise. If more women who are going to develop breast cancer are put into the study group, and more women, like you can see it more easily here, and more women die in the study group, it'll make it look like the screening caused more deaths. Now, here's the problem. All the volunteers in the clinic had a clinical breast exam by a nurse before being assigned to the study or the control group. And because women with lumps were welcome to participate, even if the nurse detected a mass, the woman was supposed to be randomized, even possibly into the control group. Now, this put the nurses in an ethically untenable position. We now know that the randomization process was circumvented for many women with lumps and that they were deliberately put in the mammogram arm. Assignment was on open lists, so it was possible for the research coordinators to deliberately and undetectably bypass randomization and assign women with lumps to the mammogram arm. For those of you who've done clinical research, you know that nowadays randomization is done centrally by computer, but in the 80s, there were no computers. Paper and pencil, yes, pencil, were used. And this is what the open assignment list looked like. So if there was a woman with a suspicious lump, it was possible for the research coordinator to write her name on the next available line that said mammogram. And then when other women came in after her, instead of going sequentially, they could just put those women's names in the blank lines. And it would be untraceable. They didn't have to erase anybody's name. They could just put it on the next mammogram line. And here's when the experts realized that there was a problem with the randomization. In the first round of the study, published in 1992, there were 24 advanced cancers, and that's defined by cancers with 4 or more positive nodes. 19 of them were in the study group, 17 of them were palpable, and only 5 in the control group. The excess of advanced cancers in the study group was statistically significant, and the chance of this happening randomly would be less than 0.003%. So this became obvious immediately that something was fishy with the women being assigned to the mammogram or the control arm. And that imbalance persisted. At the end of the study, there were 102 advanced cancers in the study group and only 68 in the control group. In the first 7 years of the trial, 8 women died of advanced breast cancer in the study group and only 1 in the control group. Now, in 2020, Dr. Copans gave a lecture about the CNBSS to a virtual conference put on by U of T, University of Toronto. Afterwards, one of the attendees contacted him. She had worked as a mammography technologist at the St. Michael's Hospital screening site of the CNBSS, and she confirmed that she had seen women deliberately assigned to the mammogram group, bypassing randomization on a daily basis. Now, that prompted a group of us to contact as many surviving staff as we could. In 2021, we published this paper in the Journal of Medical Screening. It gives accounts from former staff who witnessed participants being deliberately moved from the control group to the study arm. It received wide media attention across Canada, and we've shared it with the CNBSS authors, the Canadian Cancer Society, who funded and ran the trials, the University of Toronto, the home institution of the authors, the Canadian Task Force, and the Public Health Agency of Canada, who funded the task force. Also, there were these 3 peer-reviewed papers that were also published, and many people wrote editorials, but frustratingly, the task force has not revised their guidelines. A metric not considered by the task force is the years of life lost to breast cancer. This diagram shows the years of life lost to breast cancer broken out into 5-year increments. Breast cancer, remember, is less common in younger women, but they have more years of life to lose. So when early detection saves the life of a 70-year-old woman, she may gain 70 years of life, which is great. But if you save the life of a 40-year-old, you give her potentially 50 years of life saved. More than 40% of the years of life lost to breast cancer occur to women diagnosed younger than 50. Now, we have a natural experiment in Canada because 4 provinces allow women to self-refer to screening starting at age 40, but the other jurisdictions don't start till 50. My colleagues in Ottawa, led by a GP oncologist, Dr. Anna Wilkinson, worked with Stats Canada to publish hopefully game-changing research. They compared the stages of cancers diagnosed in provinces that screen women in the 40s to provinces that don't start until 50. In provinces that screen in the 40s, more women are diagnosed with stage 1 and fewer with stages 2, 3, and 4 than the provinces that wait till 50. But the opposite is true in provinces that start at 50. More women are diagnosed with later stage in the cancer, not only for women in the 40s, but also in the 50s. Because when you find a cancer in the 40s, it's not diagnosed in the 50s. So screening in the 40s benefits women in the 40s and 50s. And that's important because the stage of cancer at the time of diagnosis dictates the harshness of therapy required and the greater likelihood of dying. When cancer is diagnosed at stage 0 or 1, the 5-year survival is virtually 100%. If it's diagnosed at stage 4, the 5-year survival is only 22%. Now, modeling has shown that by not screening women in the 40s would lead to 400 avoidable deaths each year in Canada. And if all the guidelines are implemented, there would be 1,100 avoidable deaths each year. Now, after the publication of that reliable data, the Canadian Cancer Society, along with 2 other cancer organizations, Rethink Breast Cancer and the Canadian Breast Cancer Network, published an opinion piece in the online journal called Healthing, calling on the Canadian Task Force to review the criteria that determine when and if women are screened for breast cancer. Here's the summary of why it's important to start at 40. 1 in 6 breast cancers, or 17%, are diagnosed to women in their 40s. And remember, the cancer grows faster in premenopausal women, which explains why 27% of the years of life lost to breast cancer occur to women in their 40s. And we saw that women in their 40s who have mammograms are 44% less likely to die, and that with early detection, women can have less aggressive therapy and better quality of life. So we should screen all average risk women annually starting at 40. And starting at 40 is especially important for Black, Asian, and Hispanic women because they get breast cancer younger than white women. Their incidence peaks in the late 40s, whereas in white women, it peaks in the late 50s and early 60s. Sorry, jumping ahead here. Also, Black women are more likely to get aggressive cancers, and they have a 30 to 40% higher risk of dying of breast cancer than white women. They have to get screened no later than 40 if we're going to find their cancers early. Cancer's uncommon younger than 40, but it does happen. The incidence of cancer jumps at age 40, and it increases with increasing age. The incidence declines after age 70, but that's because women are starting to die of other diseases. But if a woman doesn't die of another disease, her own risk of breast cancer keeps climbing. Women in the 40s are often caring for young children and aging parents. They're working and contributing to the economy, and they are not expendable. In Canada, each province makes its own decisions around health, so a woman's access to early detection depends on where she lives. As I told you, in 4 provinces, women can self-refer at age 40. In New Brunswick, they can't start till 50, but they can have a mammogram if they get a requisition from their family doctor or nurse practitioner. They're supposed to be given one if they ask, but some of your colleagues don't know that, and they may refuse to give requisitions. You need only to read some of the patient stories on the Dense Breast Canada website to see the consequences. Women who are denied requisitions and subsequently diagnosed with avoidable advanced cancers. We need help in New Brunswick. We need not only to improve eligibility across Canada, we need family doctors and nurse practitioners to give requisitions to their patients who ask and to encourage them to be screened. So when to stop? Well, the task force says screening should stop at 74 because the old trials included women only until that age. And most provinces have defaulted to that. But breast cancer risk, as I told you, keeps increasing with increasing age. And if a woman doesn't die of something or else, her breast cancer risk keeps climbing. Now look at these women. Would you deny them screening? If a woman's in good health and she's well enough to have treatment, if we find a cancer, then it's worth continuing screening to find those cancers when they're small. 74 is the new 54, right? So this life expectancy chart is from Stats Canada. The average life expectancy for a 75-year-old woman is 13 years. At age 80, it's 10 years. So stopping at age 80 would be reasonable, but it really depends on a woman's general health and her personal values. I have a friend who's 84 and extremely active. She bought a bike last year and she rides 10K outside 3 times a week. Guess what? She's still having mammograms. In 7 provinces, women can continue to refer past age 74, but not in New Brunswick. Women need a requisition, which adds an unnecessary barrier. And it's especially problematic for women who don't have a family doctor or a nurse practitioner. If you care for women 75 and older who are in good health, please talk to them about screening mammograms and provide requisitions to those who choose to continue screening. My time's almost up and I haven't even shown you a mammogram. There are many ways to screen for cancer, but mammography is the mainstay, having been around the longest and having the most evidence to support it. Ultrasound, MRI, and some newer tests are also important, but let remind you, thermography has been thoroughly discredited. Both the FDA in the States and Health Canada state that it cannot substitute for mammography. These examples are of different sizes of cancer in different women. And these are the side view of the left breast in those 3 different women. The 2 cancers on the left were not palpable and they were detected on a screening mammogram. The one on the right was from a 47-year-old woman who found a lump, and her mammogram shows at least 2 separate cancers occupying a large proportion of her breast, and she needed a mastectomy. But in all of these examples, the cancers are visible on the mammograms, like in this woman. Now, we're pretty good at recognizing cancer when it's visible, but this is the segue to another issue the task force got wrong: supplemental screening for women with dense breasts. I covered this last time I spoke to you, so I'll go quickly and get to the new information. This is an obvious cancer in a 55-year-old, and it's easy to see because the cancer is white and the rest of her breast is dark gray. The dark gray is normal fat, but women's breasts vary tremendously in their background density. Unlike most organs in the body, normal breasts can look very different from one another. These breasts are all normal. Now, radiologists divide breast density into 4 categories, categories A through D. Categories A and B are regarded as non-dense, and categories C and D are regarded as dense. Mammography sensitivity, in other words, the ability to see cancer, approaches 100% in fatty breasts, but we miss up to 50% of cancers in women with the densest breasts. And the double whammy is that breast density is also an independent risk factor for breast cancer. Women in category D are 4 to 6 times higher risk to get breast cancer than women in category A, or they're about twice as likely as average. Now, when cancers are missed on a mammogram, they present as what we call interval cancers, usually as a lump. So the woman's had a negative mammogram, and at some point after that, it can be weeks or months, they find a lump in their breast. And we call it an interval cancer because it's diagnosed in the interval between planned screening mammograms. Those interval cancers are more likely to be higher grade and more advanced than screen-detected cancers with positive nodes and a worse prognosis. So we have a perfect storm for women with dense breasts. They're more likely to get breast cancer, and we're less likely to be able to detect it on their mammograms. This video shows that the visibility of cancer depends on the density of the breast, but also where the cancer is in that breast. Cancer can be missed in a breast of any density if it happens to be superimposed on even a small volume of dense tissue, like in the category B breast here. But it's more likely in higher density breasts. And a reminder, breast density can only be determined on a mammogram. You cannot tell by breast size or texture. Lumpy breasts are not necessarily dense, and firm breasts can be fatty. Both fatty or dense breasts can feel soft, firm, or lumpy. Here's an example of dense tissue hiding a cancer. This is an acquaintance of mine who had a negative screening mammogram at age 50. But remember, negative doesn't always mean no cancer. And you can see she has extremely dense breasts. 8 months later, she came back because she found a lump in her left breast. And the technologist repeated the mammogram and put this triangular sticker on the skin right on top of the lump so we'd know where the lump was. And we repeated the mammogram even using 3D mammography, but the lump did not show up. But when we did her ultrasound, we saw her 3.2 centimeter cancer. That's not small. And it had already spread to her lymph nodes. This is an interval cancer. And interval cancers are 18 times more common, actually 13 to 18 times in women with dense breasts. I see cases like this every single week in the office. So where does ultrasound fit in? Well, we don't make policy based on an anecdotal case. For many years, it was known that ultrasound could not find cancers that were not visible on mammograms and too small to feel. But that's before they developed high-frequency ultrasound probes in the mid-80s. We published this paper over 25 years ago, and it was followed by work from multiple other institutions and then multi-center trials. And it showed that high-resolution ultrasound can find cancers that are too small to feel and missed on mammograms, largely because of dense breast tissue. BC was the first province to tell all women their breast density. This paper from our clinic was published last year. My colleagues looked at the screening breast ultrasound examinations that were done on women with category C and D density, which are covered in our provincial screening program. Sorry, not in our provincial screening program. Our provincial health insurance pays for screening ultrasound on women with category C and D density. And we found 7 cancers per 1,000 screens, with a very low biopsy rate and a very high positivity rate. The cancers were small, they were real invasive cancers, and they were node negative. Now, some authorities who are considering offering supplemental screening would like to limit the access to women with category D only, or women with a family history. But I want you to note that 40% of the cancers we found were in women with no family history, and 60% were in category C. So ideally, all women in category C and D should have access to supplemental screening. This is a randomized trial of screening ultrasound being done in Japan. And it has the ultrasound screening has been shown to find more early cancers and reduce the interval cancers by half, with only slightly lower specificity. And a lower interval cancer rate is predictive of mortality reduction, but it's probably going to take another decade or more to actually be able to measure the mortality reduction. Dense Breast Canada is a nonprofit education and advocacy group, and they began advocating in 2017. Now, thanks to the tireless work of their volunteers, 6 Canadian jurisdictions now inform all women of their breast density, including New Brunswick, and 4 more have committed to starting this year. Besides mammography and ultrasound, there are many other ways to detect breast cancer. Breast self-exams and clinical breast exams are discouraged by the task force. I'm a big proponent for breast self-exam. Since most women in Canada are not having optimal screening, most of them aren't having mammograms in their 40s. And even when they start at 50, they're only having a mammogram every 2 years. Their cancers are often found by what I call accidental breast self-exam. Doing deliberate periodic breast self-exam has a chance to detect their cancers earlier when they're more easily treated. And you don't have to do it every month. Tomosynthesis is the newest type of mammogram. It finds more cancers than regular 2D mammograms, and it reduces false alarms, but it's not used by any screening program in Canada. And it's not as good as ultrasound at finding cancers in dense breasts. That example I showed you of my acquaintance, even when she came with a 3.2 centimeter cancer and we did a 3D mammogram, it didn't show her lump. MRI is the most sensitive test for finding cancers, but it requires an IV injection, and it's the most expensive, and it's not that well tolerated. It's not accessible because there aren't enough machines or trained personnel, and women just don't like having MRIs. They're uncomfortable to lie in the magnet, and people with claustrophobia really can't tolerate it. Now, contrast-enhanced mammography is the newest, and it shows tremendous promise, but it also requires an intravenous, but it's better tolerated, and it's almost as sensitive as MRI. Now, in response to recent research, the European Society of Breast Imaging has acknowledged that women with dense tissue are underserved by just having mammograms. And they know that MRI will reduce deaths and is cost effective. So they started this year recommending that all women aged 50 to 70 with category D breasts have screening breast MRI, preferably every 2 to 3 years, but at least every 4 years. They say that if MRI is unavailable, that women should have ultrasound in combination with mammograms. And they acknowledge that it might also be valuable for women with category C or less dense tissue, but they say there's not enough research yet. Ontario is actually currently considering whether they should offer MRI to women in category D. So to save the most lives and reduce suffering for breast cancer, we should do annual mammograms for all women starting at 40, ideally with tomosynthesis, and continue as long as a woman's in good health with a life expectancy of 10 years. Women should be able to self-refer and not need a referral from a primary care provider. They should all be encouraged to do breast self-exam. Now, all women should be informed about their breast density, and supplemental screening should be available for women with dense breasts. For now, best practices would be MRI for all category women every 2 to 3 years. And until MRI is offered to category C, they should at least be offered screening ultrasound. Ultrasound should also be used for women in category D who can't tolerate MRI, like women with pacemakers, for example. The greatest barrier to optimal screening in Canada is the Canadian Task Force. So my final points. A woman's risk of breast cancer nearly doubles if she has a first-degree relative with breast cancer. But not having a family history doesn't mean that a woman doesn't need screening. You may be surprised to hear that 80 to 85% of women who get breast cancer have no family history. That's why all women need to be screened, not just those at increased risk. The most significant risk factors for getting breast cancer are being a woman and growing older. And among women diagnosed with breast cancer, dense breasts are actually more frequent than a family history. There are tools online to calculate an individual woman's risk of getting breast cancer. This one, called the Tyrer-Cuzick or IBIS, is for women who haven't had cancer, and it estimates the risk in the next 10 years and over a lifetime. It's easy to use with just a few questions. Women with a lifetime risk higher than 25% are regarded as very high risk, and you can find it just by Googling IBIS risk calculator. Even though the guidelines were made without content experts, the task force gained undeserved credibility from endorsements by respected organizations, including the Nurse Practitioner Association of Canada. Most of these groups did so without doing an independent review. And that's not surprising because it was generally assumed that the task force members must be experts. So now you know otherwise. You heard me refer to Dr. Wilkinson's research with Stats Canada as hopefully game-changing. As a result, the Canadian Cancer Society officially withdrew their endorsement. Please let your colleagues in other provinces know that I'd be happy to speak to them. It would be powerful if your national organization also withdrew their endorsement, and many more lives could be saved if the task force was persuaded to reconsider the guidelines. So thanks for your attention, and I look forward to your questions.
That was amazing. Thank you, Paula. I'm just going to see if I do think there's a question from Joni. First Nations people, do they have an increased risk as well?
I don't think we have the stats on that, and it's a really good question. I know that in British Columbia, we have these fixed screening mammography sites, but we have mobile vans that go to underserved areas in the far north. So even women there can access mammography. But I don't think there's enough stats on breast cancer incidence in First Nations women.
Any other questions?
You can actually put up your hand if you want to ask a question live. It said if on the menu it says reaction, and then you can raise your hand. If we see a hand go up, then you can ask, or put a question in the chat if you prefer. Joni? Joni's got her hand up. You're on mute. No, sorry, Joni, you're on mute.
Can you hear me now?
Yes, thank you.
Okay, sorry, I was moving my phone back and forth. So just so that I'm clear, For the supplemental screenings, MRIs every 2 to 3 years. For ultrasounds in combination with the mammograms, you would, so if a woman was getting, let's say, a mammogram every 2 years, we would order the ultrasound halfway through the regular screening mammograms.
That's what I recommend, because if you're only having a mammogram every 2 years, let's say some women say, why can't I have it at the same time? Well, you can, but then you're going 2 years without any screening, without us getting another look. And if a cancer happened to pop up in between, wouldn't it be better to find it partway through rather than wait the full 2 years? Nobody, well, I don't think any province is offering MRIs on a regular basis to women, even in category D, who are not at increased risk. Most provinces only do MRIs for women who carry the breast cancer gene. And some provinces have high risk programs. And if you go to IBIS and calculate your lifetime risk, and if it's over 25%, you might be able to have MRI. Now, women who've had breast cancer, who have dense breasts, for example, even women whose breast cancer wasn't seen on their mammogram and it presented as an interval cancer, as a lump, many of them are told, no, all you need is a mammogram for surveillance. Well, come on.
Well, you know what, Dr. Gordon, even when I was when I was denied the supplemental screening, even when I was talking to my oncologist, it was kind of like, I think it was ordered because I was anxious.
Well, okay, but we've got to, this is a paradigm that has to change. Oncologists are taught that mammography alone is okay, even in dense breast tissue, because the whole dense breast tissue issue is only now getting out there with these kinds of lectures. Most family doctors listen to the task force, who say that women with dense breasts don't need any extra screening. Well, of course they do. I like to say that women with dense breasts are discriminated against if they can only have a mammogram for screening. There was one study I didn't show you done in the Netherlands that shows that women with non-dense breasts enjoy 41% mortality reduction from mammograms alone, but women with dense breasts have only 13% mortality reduction. So that ain't fair. And in the US, the American College of Radiology recommends that women who've had breast cancer with dense breasts have MRI, and that women who've had breast cancer of any breast density, if they were diagnosed under age 50, have MRI. So nobody in Canada is doing that yet. And there are pockets of really good care. Once you've had cancer, you're kind of in a different category. When I talk about the task force, we're just talking about average risk women who have not had cancer. Even the Tyrer-Cuzick risk calculator model is for women who haven't had cancer. So a woman who is dense breast, who has had breast cancer, definitely deserves supplemental screening. I see another raised hand. Nancy?
Hi, yeah, no, I just wanted to say thank you so much. This is very informative. I teach at UNB, the NPs, and we certainly go off of the task force. So having this enlightenment of it's not always that great, and having done that research, I really appreciate that. And it kind of hits home. I was just saying, I have a girl I graduated high school with, so I'm 35, or she was diagnosed with stage 3 breast cancer at 35. Years away from even early screening. And so I know, and without any family history. So it's quite unfortunate, but it just, anyhow, I just really appreciate that. And thank you so much.
Well, let me just emphasize the pitch for breast self-exam. Sometimes if a cancer is deep in the breast, even if you do regular breast self-exam, you're not going to find it early. But, if women just checked periodically, we'd have a chance of finding them earlier. The other thing, just to restate for everybody, this lecture is being recorded. And Nancy, if you want to show the recording to your students, please do. I'm sort of partial. I'm trying to slow down my clinical work, but I'm spending all the time I can lecturing to groups of interested caregivers, even lay people, just to get the word out, because the guidelines will not change because I told them they're bad. It's only when women rise up, honestly. I like to say that policymakers don't listen to experts, but politicians listen to voters.
Absolutely. Hit it right on the nail right there. Thank you.
You bet. Any other questions? Well, I know it's late for you. So thanks everybody for your attention. It was great speaking with you. Jenny just put something in the chat. What did you say, Jenny? Oh, no. Okay. There's a website, Know Your Lemons. And it's they've got a great poster demonstrating the different ways that breast cancer can manifest. They've got an egg carton full of lemons, and each lemon looks like it has a breast cancer. So check that out if you can. Are we okay to wrap it up, Chantal?
Yeah, thanks again, Paula, for your time, and we will share your video widely. Thank you.
And please talk to your colleagues in other provinces. Let's get the word out.
Absolutely. We're on it.
Bye, everybody.
Take care.